following episode is brought to you by the American Urological Association. This episode features content from the AUA 2025 meeting in Las Vegas. For more information on how to claim CME credit for your participation or to view faculty disclosures, please visit the AUA University. This educational activity is supported by independent educational grants from Astellas, Janssen Biotech, Inc., administered by Janssen Scientific Affairs, LLC, Lantheus Medical Imaging, Novartis Pharmaceuticals Corporation, and Pfizer, Inc.
All right, in the interest of respecting everyone's time, we're going to get started since it's 4 o'clock. So I'd first like to thank everyone for choosing to spend your time with us this afternoon. There's a lot of great offerings at the AUA every year. As part of its disclosure policy, the AUA determines whether disclosed relationships with ACCME-defined ineligible companies are relevant to the educational content of the CME session and mitigates any conflicts of interest prior to the session. The full disclosure policy and report of relevant financial relationships are posted on the AUA's annual meeting website. That can be found on the mobile app. All right, so the learning objectives for today are to describe the seminal validation studies for prostate cancer, list the different prognostic endpoints provided by various genomic tests, identify appropriate genomic testing based on a patient's unique clinical characteristics, review the NCCN guidelines for genomic testing, and also address advanced imaging for prostate cancer, what and when. So as far as disclosures, I'm Dr. Joseph Wagner, by the way, otherwise known as Peppy Wagner. I do some consulting for Covidian. We have Matt Cooperberg from the University of San Francisco. These are his disclosures. Peter Pinto from the NCI with his disclosures. And finally, Dan Lin from the University of Washington, and these are his disclosures. So quick overview and background. There's a difference between somatic and germline mutations. Germline tests examine the mutations that are inherited from either parent and are presented in each cell. Genomic tests examine somatic mutations in the tumor itself. And sometimes we refer to these things as molecular tests or assays. You'll hear the term genomics is sort of thrown around, but really some of these things are proteins, some of them are RNA tests, DNA tests, et cetera. Another definition is artificial intelligence. This is sort of my big bugaboo right now. I think we just throw it around with everything. I think that things that we used to call machine learning and deep learning and algorithms, we're just saying artificial intelligence nowadays. But it's the theory and development of computer systems that are able to perform tasks that are normally require human intelligence, such as visual perception, speech recognition, decision-making, and translation between languages. And this was a study that came out of Dartmouth that just sort of showed the sort of evolution of artificial intelligence. Prostate cancer in 2025. Decisions, each step along the way. It seems that every year there's more and more tests at each step, and we're going to go over some of these, obviously, today in the course. Quick review of Biochemistry 101. This is the process of protein synthesis. So we have DNA, which gets transcribed into RNA, which gets translated into proteins. And it's really the proteins that are the end action maker. But we have tests for each one of these, right? We have IMPACT as an example of a DNA test. A lot of our tests right now are RNA-based with RT-PCR, such as GPS, Decipher, and then protein tests like P10. So why do we need genomic testing? I think we all know that PSA, clinical stage, grade group, tumor volume, PSA density are all great tools, and we can combine those into different algorithms, nomograms, et cetera, to even have better tools. But they're still not telling us the whole picture. There's a lot of upgrading and upstaging, downgrading and downstaging, and the better we can classify our patients, the better care we can provide to them. A recent study from European Urology showed that 30.3% of men with favorable intermediate risk disease are upgraded or upstaged, and we found about 28% in our surgical cohort at our institution. So these are the NCCN guidelines for prostate cancer. And really the money is in the intermediate risk disease, I think. That's where these play the most role. But for high volume, low risk disease, again, I think it can play a role. And for certain high risk patients also, just to determine treatment intensity. So these are the NCCN guidelines for active surveillance and observation. And what they say is their options for confirmatory testing include prostate biopsy, MRI with a calculation of PSA density, and repeat biopsies indicated, and or molecular tumor analysis. And one thing we really wanted to make a point of is we are not up here saying that you do a genomic test, determine a patient does not have aggressive cancer, and then send them off and they don't have to worry about their prostate cancer. This is really just deciding at the initial stages, who do you think can continue down the active surveillance pathway, which will continue to involve PSAs, MRIs, digital rectal exams, and biopsies, and who maybe should move forward to definitive therapy, or who needs active surveillance, but maybe with a slightly closer eye. Repeat molecular diagnosis is discouraged. So if you're doing repeat biopsies and you find a little bit more favorable intermediate risk disease, you don't need to retest those patients. And molecular tumor analysis is not recommended for very low risk disease. So these are the three tests that we're going to be talking about today, just because they're mentioned in the NCCN guidelines, and that's Decipher, GPS, and Prolaris. They can all be used in the diagnostic, meaning testing the biopsy setting. And then in the post-prostatectomy setting, the two tests that can be used are Decipher and Prolaris. So which test should you use? There are many pre-biopsy choices and sequences that we're going to be talking about today. It's very nuanced. We chose Prolaris, Decipher, and GPS for the reasons I stated, but there are others. Artera is the first pathology artificial intelligence tool in the NCCN guidelines. We're going to be going over that this year. And then what endpoint is more useful to you? We're going to describe how all these tests came about. What endpoints were they trained for? Do you think it should be prostate cancer-specific mortality with conservative treatment? That was one of the pre-test questions with Prolaris. Adverse pathology, metastasis. And then what's your prostate cancer volume in your practice? Should you just get comfortable with one test and learn how to use that well? Or do you want to change your test with clinical situations? And there's no best tests and no head-to-head studies. A number of years ago, I took a number of men who had more than one test, a GPS and a Polaris, a Decipher and a GPS, et cetera. And usually they correspond with each other as you thought they would. When they do have differences, you might see one test leaning a little more toward active surveillance and another one more toward treatment, but they're all good tests. So what we're going to do today is we wanted to really structure our course a little bit differently this year and make it even more of a flipped classroom format. So we really want people to be involved, raise hands, ask questions, but we're sort of viewing it as a sort of enhanced podcast. So we're going to go through an index case, stop along the way. I'm going to ask our panel what they would do, what do they think about things, but I encourage everyone to get involved as well. So here's our index case. A 62-year-old man presents to you with a PSA of 8.2. You repeat the PSA, it's 7.8 with a free PSA of 20%, no past medical history. Has a brother who underwent a radical prostatectomy at age 65 with grade group 4 disease. He was PT2, margin negative. The patient's digital rectal exam is unremarkable with mild LUTS and good erectile function. So I'm going to ask the panel first, what's your recommendation? Transrectal ultrasound, prostate biopsy, with or without MRI? An MRI, a trust biopsy if the MRI is positive, but following him if he's negative based on studies like Precision and Promise, or do you do an adjuvant test such as 4K, PHI, and exosome? And I'll tell you one thing that's really a hot topic in our institution right now is just the digital rectal exam. So I might start with that. I'm a dinosaur up here, and I'm still doing digital rectal exams, and a lot of my partners aren't. So what are people's feelings on the DRE? Because they just say, I'm getting an MRI, right? I got a 3 Tesla MRI, and my finger's probably a 0.1 Tesla. Why are you doing a digital rectal exam? So what does the panel think about DREs?
I'll start with a DRE, easier one. So I recently helped chair the AUA guidelines for prostate cancer detection. If you look at those guidelines, we downgraded a DRE this year. So it used to say always screen with PSA and DRE, and now it says you may do a DRE. In other words, you don't have to. Why is that? Because DRE as a screening tool is remarkably bad. It's terrible, actually, by itself. However, in the fine print in the guidelines, we did say if a patient has an elevated PSA, then DRE does actually have some utility insofar as detecting higher grade or higher risk disease or nodules and so forth. So the current recommendation is don't use it for screening, but if someone has an elevated PSA, I think it's a very reasonable thing to do, in part because one gathers, you can, in certain situations, find a nodule, find is it fixed, is it T3 into the seminal vesicles and so forth. And so I would probably do a DRE in this patient, although I would probably tell him I do it at the time of his biopsy. So I'll see him in clinic. I'll say, I'm not doing an exam today. You're getting a biopsy. We can talk about MRI versus not. And I'll do the DRE at the time of the biopsy.
It's important to, and actually, by the way, as someone who's not on the guideline, if you haven't seen the AUA early detection guideline, it's a really, really good one. It's one that you should be prepared to communicate with your primary care referring community about. We talk a lot about the NCCN in this course. The primary care docs tend to just read the U.S. Preventive Services Task Force guideline, which at this point is grossly out of date and was not that accurate when they wrote it in 2018. The AUA one really has a lot of great info in it. The one thing where I think there's confusion about DRE, DRE as a screening test is very low utility. And to the extent that patients don't like DREs and they think they need a DRE for a screening exam, it's a barrier to screening. But once the PSA is elevated, meaning above 1 or 1.5, it's part of the workup. Or if somebody has voiding symptoms, this is part of the workup of urologic symptoms or an elevated PSA. That is different from screening tests. So I absolutely do them for guys that are in for an elevated PSA. Frankly, if they've got like Dan, we're seeing a ton of remote health. It's often easier to get the MRI before I even see them. But if I'm seeing somebody for the first time without imaging and they've got a clear nodule on DRE, we should save the money on the MR because we're going to see the lesion on the trust biopsy. We're going to find the cancer, and then we're going to do the PET scan.
And then Peter's our radiology expert. I think I know what you're going to answer, but immediate biopsy, or are you doing an MRI?
Well, DRE is a big point of contention for me. So I think your finger, put it up again. That's a 0.55T MRI in my mind. So don't kid yourself. That's actually a nice finger. Actually, this finger is very important. We do things like ultrasound, which are beam mode grayscale. But there's ultrasound waves that can actually determine stiffness of tissue. Okay, and there's technologies that we're working on, others are working on, that's going to bring that kind of finger back into the diagnostic pathway. Okay, we know that, I'll get ahead of ourselves, MRI does a really bad job in finding the tumor's volume, extent, things like that. And so we're working actually on the opportunities to understand with more than just MRI where these tumors are going. But for me, in the OR, I think, Matt, you're right. I think it's a barrier to screening sometimes. I think men hesitate to come into clinic, knowing that there'll be an examination like that. And, if you incorporate MRI in your practice for an elevation of PSA, and, our colleagues, in the UK often do that, it's part of the pathway of the NHS, then I think I would forego the MRI, the biopsy, the finger dissection, DRE. Now, for those who do DREs, who does DREs in their practice usually? Right.
Almost.
Okay. If you take a person to a biopsy, who does not do a DRE at the biopsy? Who does not do a DRE at the biopsy? But you raised your hand before, so you got it in clinic. Okay. So what we're saying is we all do DREs at some point. At the biopsy, even if I have an MRI, I do want to, at least get a feel for what's going on. And the interesting thing I've come across in my trainees is this. If you feel a nodule, an ultrasound does not see the nodule that you felt. An MR doesn't see it. Or if it's stiff in a certain region of the prostate, I've asked the audience for the past 10 years what they do, and very few individuals will do a finger-directed biopsy of that area. For good reason, right? It's scary, right? We actually do that. We have a trumpet, and it protects our finger, and the tip of my finger can feel that nodule, and I slide the biopsy gun through the trumpet. We designed it. I didn't commercialize it. It's just in our OR, but we sterilize it. I wear 2 gloves, and the tip of my finger feels that hard area, and I'll biopsy the area. Now, I don't imagine the yield's very high, but my point is, if you're going to do a DRE, and you find an abnormality that it's not visible on the imaging modalities, I think you should figure out a way to at least sample that area, because otherwise you'd miss it. And so if you're not going to do that, then keep the finger out of the rectum. That's all.
One final point, though, too, is that don't forget the HACC staging manual is still based on DRE.
Right.
Okay, so as much as we can argue whether it should be in 2025, if you want to stage these patients accurately, you need the DRE. It's a very, very common misapplication of coding. Somebody's got an MRI lesion and a negative DRE. That's a T1C. We see it done incorrectly all the time, and it probably doesn't matter because T1 versus T2 matters very little in risk stratification systems. But just bear that in mind too. If you're, from the oncology practice standpoint, accurate staging still does require the DRE.
So maybe a quick, yes. And if you can come to the microphone, or I can repeat your question, whichever you prefer. Just for our internet audience.
DRE is definitely not going to hurt anybody. And you're definitely going to pick up other things besides prostate cancer issues. I've picked up rectal cancers. But what about the patient with hypogonadism who has a low PSA and a prostate nodule, and they come back at a high-grade prostate cancer on biopsy? And then with regards to the trumpet, there's a little plastic sheath over that needle. You just cut that in half, and you stick that right in there, and you slide the needle through there, so you don't have to worry about that trumpet.
That's what we did recently. I won't say the company's name, and we cut it flat, then we cut it at an angle, and then I had to ranger off the tip because it was scratched from my foot. So we just made the trumpet. But you're 100% correct. That biopsy guy, and it's nice and stiff. And listen, I'm not going to take too much time on this, but you cannot pierce that sheath with the gun.
Understand.
Fingers protected. Right. We got to talk.
Then last point. Last month, I diagnosed a guy with sarcoma of the prostate on a DRE with a normal PSA.
Yeah, they happen. They happen. So quick show of hands. Who would do an immediate biopsy on this patient? Great. And who would do an MRI and let the MRI guide them? And who would do an adjuvant test such as 4K, PHI, et cetera? All right, maybe a good segue for Matt to get up and talk to us a little bit about these pre-diagnostic markers.
I feel like this is a UK type audience. Very, very interesting. So, in the UK, you probably know the paradigm is you have an elevated PSA, you get an MRI, no biopsy. And actually, before we leave this patient, so I would get an MRI too, but there is a question how you're using the MR. So 62-year-old, PSA is 8, truly 7.5, MRI negative. Who still does a biopsy, systematic? And who would not? Okay, so mostly we're talking about MR as a guide, not as a secondary test. And it's a really, really important distinction. Because one paradigm, including the UK paradigm, is the MR is your secondary test. And MR negative, again, you can decide whether that's defined as, Pirates 1-2 or Pirates 1-2-3, negative MR, no biopsy. And that, I think is questionable, it all depends on how good your MR is.
And also whether it's the biopsy naive person or a previous negative biopsy.
Yes.
The biopsy naive person like this who's never had a biopsy, MR is negative, is different from someone that's had a previous negative biopsy and an MR negative. They're very different populations. In the AUA guidelines, we made a very big distinction between the two. So just look at that.
Yeah.
I also add you should look at the MR if you can, at least initially, if you have a new MR physician or radiologist, because the image quality can be very different. And I see you shaking your head. That's true because you don't know what you don't get if you don't see it. And remember the days of IVPs? Most folks don't know what I'm talking about, but if you do, CT urograms. How many times was the ureter not filled out by the contrast? The radiologist says no ureteral tumors. We had to go back to the cysto retrograde and fill out that ureter. Yep. Radiologist didn't tell us that, so keep that in mind. Same thing with prostate MRI.
Yep. So, before we start spending any money on imaging or secondary tests or anything, we really need to be using the existing tools as well as we can. And this applies in both the pre-diagnostic and post-diagnostic settings. And, I love giving this line to the primary care audiences. This is true. PSA is like the best marker in the history of oncology, despite what they tell the medical students. The issue is just that we did not use it well when it was launched in the 90s. So, PSA was developed amongst men mostly in their 60s and 70s. They all had BPH. We tended to overscreen men at too late of an age with too high of a threshold at 4.0. We underscreened younger and healthy men. We overtreated every group 1 cancer we could find. We undertreat high-risk disease pretty frequently, and 4.0 was a terrible threshold. Despite all that, we drove the mortality rates down 50%. Okay, so the problem is, and the reason the task force came back and said de-recommendation in 2012, don't screen anybody ever, was because of the way PSA was rolled out. So it was the wrong answer. It was the baby out with the bathwater, classic case of that. But if we use PSA well, it is an incredibly good first test. Better than truly any other screening test in oncology, mammography, colonoscopy, what have you, if you use it well. So what does using it well mean? Well, first of all, again, you have to ignore 4.0, and you all probably have some sense of this, but I would bet you that your referring primary care community still think about 4 as the threshold for normal, or maybe if they're enlightened, they're thinking 3, which is really too high if we're using PSA well, which means screening in midlife. So this is a summary chart from Mark Preston, who did a study in the Southern Community Cohort study, which is a heavily African American cohort in the Southeast U.S., but it's a follow-on to a fantastic study out of Malmo, Sweden, from Andrew Vickers years ago. Malmo is a beautiful case study of why everybody wants to be an epidemiologist in Sweden, because they do things like round up the entire city population and draw blood on them in 1982 and follow every heartbeat from birth to death in the record systems, which you can do in Scandinavia. Nobody ever moves. And 20 years later, Hans Lilja at MSK got access to this archived blood, managed to run PSA on this very old archival blood, and demonstrated that a single midlife PSA is incredibly predictive of not dying of prostate cancer over the long term. So the Malmo study is on the right here. This is the Physicians' Health study out of Harvard in the middle, and the Southern Cohort study on the left. The point here is it's very, very consistent. In your 40s, the median PSA is around 0.7. Okay, by the time you get to your 80s, it's about 0.8, 0.9 by your late 50s. By the time you get to 60, it's about 1.0. And all the action is in these red bars here, which is the top 10th percentile. Okay, never mind the top half, top 10th percentile, where the thresholds are 1.7, 1.9. These are the men that actually die of prostate cancer. You can say maybe the top quartile, which is around 1.1. So most of the contemporary screening paradigms which are emerging, not quite in the guidelines yet. The guidelines, except for the task force, are all saying start around 45 or 40 in the presence of risk factors like Black race, family history, certainly anything in terms of genetics, germline genetics, which we'll talk about in a minute. So a threshold of 1.0 or 1.5 wipes out 75% of the population. And this is, if you believe Malmo for 20 years, you can stop worrying about PSA with a $20 test that the primary care doc can do, without really thinking about it. The reason 1.0 is a terrible threshold in the old paradigm is that's way too many biopsies. But now we have all these other tests. So, the smarter screening, the contemporary screening concept is, screen at midlife, not in the late 60s, screen right in their 40s and 50s with a threshold of 1 or 1.5. And for everybody above that threshold, you don't go straight to biopsy, you do something else. And there are more somethings than we can keep track of. The font on this slide is smaller every year, and soon I'm going to have to change it because we can't even keep track of how many tests there are out there. We've got blood tests, urine tests, and now the polygenic risk score, if anybody saw the barcode trial out of the New England Journal a couple weeks ago, all competing with multiparametric MR, actually, as secondary reflex tests to try to figure out which men with elevated PSA should actually go on to biopsy. I'm not going to go through these exhaustively, but we'll give a couple of highlights. Now, a couple of points to emphasize here before you start spending money on these tests is that any marker has to improve on a multivariable gold standard. So it's actually not quite good enough to just beat the PSA. There are a number of risk calculators. You guys may have seen the prostate cancer prevention trial calculator, for example, or there's the ERSPC out of Europe, Sunnybrook out of Toronto. These are all pretty easy to use calculators that integrate age, race, family history, DRE findings, and PSA to give you a likelihood of high-grade cancer. And to do these studies well, which honestly most of the contemporary studies check off all these boxes, there are published guidelines in terms of how to do biomarker work reliably to avoid the biases that otherwise inevitably creep in if you're kind of selecting cases ad hoc. And this is a critical point here, the goal is not find prostate cancer. The goal is find potentially lethal disease, which we generally define as grade group 2 or higher. And this is a really important point. When you order any one of these tests, including an MRI, you are saying implicitly what we're looking for is grade group 2 or higher. If we have a positive test, we're going to do a biopsy to find the grade group 2 or higher. If the test is negative, that means there's either nothing or there's grade group 1. In either case, we're not going to do the biopsy. So it is important to think about that for a minute. When you think about what we do with grade group 1 after diagnosis, we are trying really hard not to find it. We are making it into an incidentaloma, which it's a side conversation. A lot of us would argue we should not even call cancer. So here are the tests that we can consider in 2025 before a first biopsy. 4 different blood tests, 4 different urine tests, plus multiparametric MRI, and now this polygenic risk score. This is the PCPT risk calculator, this is the one thing that I will actually leave Epic, leave the EMR to go run in the clinic, because the report here, the Smileygram, is just a great teaching tool. Patients kind of get this. Ian Thompson actually developed this when he first put this out. His argument was, when they originally planned this, it was supposed to be that the guys with a negative biopsy were yellow because they just went through this unnecessary painful procedure. The guys who had low risk disease are the sad ones because they've been overdiagnosed with grade group 1. The ones with high grade cancer should be happy because you saved their life maybe by finding the high grade cancer. Obviously, the patient focus groups they ran this with did not see it this way, so this is the way we have it. But it's it's a very good tool, and two guys can see the same 12% risk of high grade disease. One may choose a biopsy, one may choose not to get a biopsy. Again, this is a point Ian made when he published this. That is a good decision in both cases, as long as it is an educated decision. So once you have this as a background, then you decide whether or not to run an additional test. If somebody's got a 40% chance of high-grade disease, he needs a biopsy in almost any consideration. You don't need to run a secondary marker. So I'm going to give just a couple highlights on some of the emerging tests. 4K and Phi are both blood tests that are based on isoforms of PSA, subsets of PSA. This is the reason I'm highlighting this study. It's one of the only ones that ever looked actually two tests head-to-head. This was out of Tobias Nordstrom out of Karolinska, ran both 4K and Phi on a pretty large cohort of men, and they both work basically equally well. So is anybody not familiar with an ROC curve? Don't be shy. So all right, you always want to be up and to the left. You're going to see a lot of these throughout the course of the course here. The identity line along the middle here means no better than a coin toss, right? So the base model here, which in this case is the PCPT calculator, doesn't do so well in terms of identifying high-grade cancer. Both the Phi and the 4K perform more or less comparably well in terms of improving likelihood of finding high-grade cancer. This is one of the most recent ones. So the MPS version 1, which was based on PCA3 and TMPRSS2 ERG in the urine, is now updated to 18 different genes. This is out of University of Michigan and Royal Chennai lab originally. The really recent update on this is the newest version of it does not require a DRE. That was literally a poster downstairs yesterday. So this one, along with ExoDX, these are now urine tests which can be ordered just by sending the patient a kit. And for those of us doing a lot of telehealth, in San Francisco, our catchment is hours away. It was never practical to drag somebody in for a DRE just to get a marker test. So this one, along with ExoDX, can now be sent by mail. The patient just mails it in, and we get the result back in a couple weeks. And this is looking at the MPS Plus actually incorporates the clinical parameters along with the score itself. And this is working pretty well. So the graphs here, this is instead of an ROC analysis, this is called decision curve analysis. So this is looking across a range of so-called threshold probabilities. You want to see that your test is kind of up and to the right now. And the threshold probability is basically, what's the implication of being wrong? So if the test is wrong, if your threshold is 20%, it means you're willing to accept a 20% chance of having an unnecessary biopsy, for example. So if the intervention is like prostatectomy, you want a much higher threshold, right? If it's just, taking a dose of Cipro, you're going to be far to the left. So you want to see that the test is effective across a broad range of threshold probabilities. And this is what we're seeing here. The MPS is the dotted line up at the top here. And they're now calculating as well the number of biopsy reductions, and it's nearly half of all the biopsies out of 1,000 patients. SelectMDx has been around a little bit longer now. This one still does require a DRE. It's two different RNA markers. A lot of the original validation here were out of the Netherlands. It's been looked at in the VA system as well. Again, works quite well. ROC analysis, decision curve analysis, it's the curves of where you want them to be, up and to the left in the ROC, up and to the right in the decision curve. None of these has been looked at head-to-head. ExoDX is the other one I mentioned. This is back to PCA3 and TMPRSS2 ERG. The difference with ExoDX is they're looking at the proportion of the RNA that is in the exosomal components. So rather than just looking at free RNA in the urine, they're looking at the RNA actually secreted in these little exosomes. So because of that, they were the first ones that were able to work without a prior DRE. Aside from the 4K and Phi, no head-to-heads. So nobody would say that one of these is better than another. They're all comparable in terms of cost. I will say we've used all of them at UCSF, and they all work. I don't have a particular strong feeling. As the head-to-head data come out, I mean, there are some suggestions that the bigger gene panel in MPS maybe will have some additional benefit, but nobody's really proved that head-to-head yet. Final one here, Stockholm 3. This is interesting because their kind of emerging paradigm is actually a two-stage test. So, this is a combination of the 4K markers, so the 4 PSA isoforms, together with a set of polygenic risk score variables, and with the addition of a couple of the protein markers as well. It, again, is around $700, but the difference with this one is a primary care doc can order this And if the PSA component of the test comes back under 1.5, they only charge $50, $70, and they're done. Whereas if the test is positive, then they run the rest of the markers. So, from the primary care vantage point, this is interesting. They've had a couple of big New England Journal studies in European cohorts, in Scandinavia and the UK, and they're starting to come into the market here. And it's definitely one to keep an eye on. So, again, I'm not making any statement that any of these is any better than any other, but I will say, based on, this is important based on the show of hands we did at the start here. In my view, these are better secondary tests than MRI today for patients deciding whether or not to do a biopsy. Not for the question of MRI is going to help you do a better biopsy, but elevated PSA, do we do a biopsy or not? These tests all have NPVs in the 95 to 98% range, which is much better than MRI, which is typically around 90%. This is the original PROMISE trial where it was as low as 76%. But this was based on saturation biopsies, so it's a little bit unfair for MRI here. They were looking really hard to find grade group 2 or higher in this one. There's a more recent meta-analysis that shows about 90% NPV for MRI in expert hands. Okay, that is in the center. That's in the setting of a center which is doing MRI day in, day out. It does not apply to community-based MR. And again, this is not because Peter Prento is going to talk a lot more about this. The problem is not MR. The problem is PIRADS. And we need to do better than the existing PIRADS system if we want to use this as a reflex test. It's also too expensive in this country. Now, the UK, this is the secondary test because it's about 200 pounds. And in most parts of the civilized world, it's under $500. In the US, of course, it can be thousands, whereas it's hundreds for most of the liquid tests. And by the way, we're talking about DRE as a modality not to abandon. Please don't abandon TRUS as a diagnostic modality. There's this comment out there that TRUS is a great way to find the prostate, not the cancer. And that is just not true. With the contemporary machines, this is not even the micro-ultrasound that Laurie Klotz just published his trial on. Standard, contemporary machines, we can see most of the PIRADS 4s and basically all the PIRAD 5s as a hypoechoic area. So if you don't have access to good MR,
I will add also,
please
take the time to look for this.
Yeah.
Right.
Yeah.
So what happens is, and I have a lot of people, they finish residency, they're coming for fellows, and they just blow through this too quickly. Yeah. If they have an MR Fusion platform, and I like to slow down and look for it. Yeah. That's the thing. You will find things.
Yeah. This is actually a nice study one of our fellows did a few years ago, looking at 200 consecutive cases, what modality identified the highest grade cancer. So we did a systematic biopsy, targeted biopsy by TRUS, then took the drape off the Euronav and did MR targeted. And it was only about 6.5% of the cases where the MR uniquely identified something. And this is just an example case. In this one, actually, you can see a little bit of bulge of the capsule there. This was T3 disease that the MR actually did not pick up. So, good ultrasound absolutely remains, really a critical part of what we should be doing in urology. And last thing, remember, none of these really tells you what to do, okay? Everybody wants to test where it turns blue, you take out the prostate, doesn't, you leave it in, and it's just not the way the biology works. All these tests have a threshold, but remember, if you're barely over the threshold, that's not the same as being way over the threshold. So EXO, for example, at 13.5, patients 14, maybe that matters, maybe it doesn't. If it's 70, that's a big deal. Okay, the 4K score has a threshold around 11, 12%. If you're just over that threshold, you can still have a decision about whether or not you're going to go forward with biopsy. When the 4K is 60%, that's much more of a direct a directive that you should go forward. So there are absolutely no guidelines in terms of how we should incorporate these tests, and you can do anything of the following: PSA followed by MRI followed by biopsy. You can do a marker then biopsy. You can do a marker to decide whether or not to do an MRI. To help you do the biopsy, you can flip this and do an MR, only get a marker if the MR is equivocal, or if the MRI showed something and the biopsy was negative, you get your marker. You can spend all the money and do all the things. And all of these things exist across the country. All these things exist even at UCSF, okay, within, across our practice, different practitioners, even different patients. So, and nobody's arguing one is better than the other. This is what I personally do most often. I think it's what we do at our center most often for reasons of cost and convenience as much as anything else. So that's about it. First of all, use PSA well, and I cannot stress enough how important it is that you be in touch with your referring primary care docs about using PSA well. We have an embarrassment of riches now in terms of secondary tests to use to try to help us decide who really needs to go forward with biopsy. MR is a great guide for biopsy, and by the way, so is TRUS. Do not forget this. We can talk about micro-ultrasound as well if anybody has questions about it, to exclude high-grade disease. So that's about it. Questions? Please.
Where does ISO PSA fit?
Yeah, great. So ISO is a newer one. They They deserve a slide here. ISO is yet another isoform of PSA. I would say the data that they have, yet again, look pretty similar with a negative predictive value in the 90s. It's similar in terms of cost. We actually have not ordered any at our institution yet, but we probably will soon. It's like 4K. So the urine tests, you kind of want the ones that don't need the DRE for convenience. The blood tests, it's a question of where is there convenient ordering through either your local lab or can you send it directly to a reference lab. I think ISO ultimately is probably going to look more or less similar to 4K, I think, but it's a little bit newer and probably less experience with it yet. I don't know if anyone else has thoughts on it. Great. All right, excellent. What's everybody using? Urine tests, ISO, MPS, blood tests like 4K, ISO, both? Never heard of any of these before? No, I'm serious. That's why we're here. No, I'm serious. No, I'm serious.
If you did, we should stop the course. So this is good. All right. So we're going to focus on. So let's clarify a distinction. If you're going to get the biopsy, regardless of the results of this biomarker test, I think we really should get the MRI, right? And so that's the thing. It does make a better biopsy. If you're uncertain about the biopsy, then the MRI can be paused for the biomarker, as Matt described. One thing Dr. Lin mentioned, I think has to be reminded. Dan distinguished between whether this is a first-time biopsy or not. Keep in mind, if you're a patient coming to you and say, listen, I've had a community urologist who's not doing MRI, I've had 3 or 4 biopsies in the past, I already have cancer, he wants to know what's going on. The MRI may be important, so keep that in mind too. And ultrasound, sometimes the hypoechoic area is not the cancer. So, I'd love to have BMO grade scale be the answer, replace MRI, but it's not yet. So just because it's hypoechoic doesn't mean it's cancer. You could biopsy it, you're there, doesn't mean it's cancer. And please, 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 I would hope at least at this time, you are considering foregoing just the systematic biopsy with no additional imaging. Imaging is improved. We're going to mention briefly about improvements in the ultrasound, micro ultrasound, for example. We obviously know about MRI. It's been here now for many, many years. I think that what you want to avoid is a urine or some other biomarker, blood-based biomarker that gives you a suspicion or confirmation that you do have a cancer in that patient. And so I'm a little bit different what Dr. Kuperberg said. I would say if you're thinking based on your PSA test or secondary confirmatory biomarker that you need to do a biopsy, I would get an MRI if possible, because if that blind systematic 12-core biopsy finds no cancer, you don't know if you missed it, or you don't know if you've never had that cancer in the prostate because the biomarkers were falsely leading you towards cancer. And so this is robust data. Many centers across the world have done specific rad path correlation to understand which sequences are required for MRI, because the MRI is not just your garden variety MRI. If you do not ask your radiology groups, they may not provide you the best imaging for your patients. I alluded to before this transition from IVP to CT urogram. I did a lot of cysto retrogrades to complete my diagnostic workup of my hematuria patient to make sure there was no tumor in the ureter. I would argue that the MRI initially is difficult and costly for a patient. They would put a 32-channel coil on the abdomen. They would put a coil like this in the rectum. They would use a 3T MRI. But these are the initial sequences. I was a chemistry major in college. I love spectroscopy. It looks at the citrate choline levels in prostate cancer. It's wonderful. This is not practical, right? And we've evolved from this. We're at a point now where you can do a much less expensive, less difficult scan to tolerate by the patient by what's called biparametric. And we don't have time to go through all the data, but I will say this. This is kind of like the next evolution. Quicker, just as good. And we didn't really speak about artificial intelligence in this course, but artificial intelligence is designed beautifully for radiology images. We will see an improvement in diagnostic quality from this by these tests. And price will come down, and the scan time will come down, and there's lots of information you can use there. Now, the PSA stands in this case for public service announcement, because you have to understand that the image on the right, which looks like, well, I'm not sure what that looks like really, but it's scary. That was sent to me by a urologist who said, I got the MRI back from my center. They say it's a pyrite. There's no lesions. Everything is fine. PSA keeps rising. I'm worried about them. I'm like, send me your films. And I said, well, just by look at that, the most important part of the prostate, the peripheral zone, which harbors most of the cancers most often, is not seen well because the technician didn't take the time to sequence it correctly. And Kuperberg's correct. We need more, I would say, standardization of acquisition of images, not even interpretation, but at least be assured you can dictate that with your radiologist by looking at the films. That's what I'm trying to say. And then, yes, the second part of this is that the radiology films given to multiple readers can be different across different areas, and PIRAT score isn't really going to help us, but there's help on the way, and I do think that there are wonderful computer-assisted diagnostic systems that will help us. Remember the days of EKG, when you took those suction cups, the little red suction cups, put them on the chest, got the rhythm, had no clue what it was, because you were the urology intern covering the cardiac service, right? And now you get a full readout with a pretty close to cardiac level interpretation of the rhythm and rate. We will see this in the future for MRI, the prostate. Do not fear, it's coming, and that'll be helpful. And by the way, I think urologists, if you stay in touch with radiology, can almost get parallel to the diagnostic team and be really involved with opportunities for diagnosis and treatment, real-time treatment. And then this was alluded to before, level 1 evidence from an amazing team. This was at UC London and other members at the UK showing that this is much better than what they call B-mode grayscale ultrasound. I keep saying B-mode grayscale because there's going to be new additional ultrasound imaging tests and diagnostic devices that will improve things. Now, there is a plethora of systems and devices out there to bring in a software system to register and target the MR lesions as opposed to having to biopsy in the MR machine. I will say that you will be hearing about opportunities to use your human brain called cognitive software registration, where the mind without software, but the mind kind of lines things up to direct it in the ultrasound to an MR area. I would say that the software systems now have a little bit of an edge over that, but maybe not for long. But regardless, you have to trial your system, see what works for you, but there is some type of registration involved, whether it's your brain or a software platform, to make sure you're correct. And if you use a software device, the time it takes to understand how the ultrasound of the prostate looks and maybe find a lesion, as Matt mentioned before, also helps you align the images, ultrasound, MRI, so you do hit the MR lesion in your office. And this is just some of the early papers that reflect this. We were very fortunate to have a large database of patients that we published on, and this is now old data, 5 years old. It's just safe to say this, that there is a trend by patients to stop getting additional biopsies, and they will say to you, I've already had a 12-core biopsy, I just want the MR targets, I want to forego those biopsies. And at least in our series and other series, and I just came from a session this morning, if you're in a biopsy session with a patient, and most people, we can discuss this in a moment, are doing these transperineal where the harm of infection risk at least is less, maybe some more discomfort in the published series, there is still some value to a 12-core biopsy. Now, you have to decide, is 8.8% high enough or not? In other series, maybe a little bit lower. But to me, my pathway is I discuss it with the patient, and I see what they want to do, and then we come to a conclusion. Now, I will say this. In this paper, what we did is we had about 400, 500 patients who went to surgery, and we had the prostate pathology in our hands, and we could look back at the biopsy technique. So for every one of these patients, in one MR session, we had a full report of where the lesions were by a radiologist. And then at the next biopsy session, we did the MR ultrasound fusion sampling of the MR targets, and we also did 12-core biopsies. And when you analyze just the 12-core biopsies, we found, consistent with decades of publications, that a 12-core biopsy following a PSA with no additional imaging led to a surgical specimen that had about a 30% risk of having a more aggressive cancer. You wonder why in the early part of our urologic history in the 70s, 80s, 90s, people were hesitant to go on surveillance, because you had to understand that there's a third of the patients you put on surveillance that you thought was low grade had high grade cancer. But when you did the MR targeted biopsies alone and not do anything else, that improved, and we had less aggressive cancer and upgrading, but it wasn't perfect. it was still about 18% of patients, and that's still not, in some people, still too high. When you spend the time to do both biopsies, the MR-directed and the 12-core, at least in our series, you look at those surgical specimens, the risk of finding high-grade cancer drops under 10%. So now you have less uncertainty by the physician and the patient. And they say, well, listen, if I had a 12-core biopsy with MRI directed also at the same time after MRI, and my risk of finding worse cancer is under 6-7%, you know what? Maybe I will go on surveillance, have more comfort. So at least in regards to imaging modalities, the MRI has a role in understanding when to biopsy. And then when you do biopsy, it is a bit better biopsy than just the grayscale B mode that we use today. All right, back to the index case. Any questions?
Yeah. Questions from the audience? All right. So our gentleman went on to have a 4K test after talking to the gentleman in the middle who was doing the blood tests. 23% risk of clinically significant prostate cancer, had a PIRADS 3 lesion, left mid peripheral zone, had 8 out of 12 cores, random systematic with grade group 1, fairly high volume, and the region of interest also high volume grade group 1. So the next question is this patient a candidate for germline testing? So I think what I'll ask first is, who discusses germline testing with their patients? Great. And of those of you that are discussing it, how many do in-office testing? And how many send patients to the genetic counselor? Great. And then how many people feel this patient is a candidate for germline testing? Excellent. Yeah, his brother, mainly because of his high-risk disease. So we're going to have Matt talk to us a little bit about germline testing indications and best ways to get it done.
Great. So this is a rapidly evolving area where we are seeing more and more indications for testing, supported by all the major guidelines, including the NCCN, which has a specific guideline now for germline testing. Let's forward here. Okay, great. So there were 2 consensus conferences sort of back-to-back in 2019 and 2020, just gathering evidence on the specific genes that are of interest when it comes to prostate cancer risk. And this is still relatively current. There are more and more genes which are being added, but they tend to be fairly minor. Now, it's important to recognize that this, and there's a slide on this later, the genes that we know about account for a relatively small proportion of the known genetic heritability of prostate cancer. This is the most heritable of all the major human cancers, but there's no single smoking gun like BRCA1 in the case of breast cancer that explains a high proportion of the inherited cases. Much more of it is polygenic. But this is a list of genes that you should generally know about. It's BRCA1 and 2, ATM, HOXB13, and CHEK2. Those account for the large majority of mutations that I think we're seeing in office. The other one's MSH. These are Lynch syndrome genes, MLH1, PMS2, PALB2. We're personally seeing these more and more. This is another question for you guys. Are you seeing patients coming in now with a mutation because their sister had breast cancer, their mother had ovarian cancer, they've got a mutation and a PSA of 0.4? Are you seeing patients like this? Do you know what to do with them? What do we do with these patients? Because I have no idea. So, Dan is actually starting a multi-center study called Patrol to try to figure this out, because we truly have no idea. The guidelines are quite good and quite clear about who should get testing. The guidelines are completely silent in terms of how should we do things differently if there's a mutation. Aside from the fact of saying, think about a PSA test 5 years earlier, there's really nothing else beyond that. We don't know if we should use PSA thresholds differently. We don't know if we should biopsy differently, if we should interpret imaging differently. All these other secondary markers, if you've got a built-in BRCA2, do you think about a 4K result differently? We don't know anything. And this is why the collecting a prospective cohorts can be really, really important. So as I said, the NCCN has its own germline testing guideline. Just to summarize from the complicated slide, these are the current indications. And this list has gotten longer every year over the last few years. So anybody with metastatic disease now should get germline testing, in addition to somatic testing of the MET. Anybody considered high or very high risk according to the NCCN. Now, I think there's a lot of room for clinical judgment here because the NCCN risk classification remains terrible. Somebody with grade group 1 and a PSA of 21 is like high risk, but that person does not need germline testing. So when we say high risk here, we're talking about the high grade, grade group 4 or 5, those sorts of situations. Anybody with a meaningful family history. You guys all know prostate cancer is extremely common. Everybody has a cousin or an uncle or what have you. We're talking about close relatives, so first-degree relatives with breast cancer before 50, any triple-negative breast cancer, and these are actually updates. These are some of the ones that were not so clearly stated in the past. So any male breast cancer, any ovarian cancer, any pancreatic cancer, any triple-negative breast in the family justifies a germline test, or any family member with metastatic high-risk or very high-risk prostate cancer. So our index patient here qualifies on that basis. And then any 3 relatives with prostate cancer at any age or risk. So, even if, grandpa plus 2 cousins had grade group 1, technically they're eligible for testing as well. And then finally, any Ashkenazi Jewish heritage. Now, a lot of the mutations, a lot of the genes I showed you on that list are genes that are related to DNA repair, both in terms of single strand and in terms of homologous recombination. You do not need to know the details of this in terms of knowing which genes we're looking for, but it's important to have a general familiarity with this because these are also pathways that we are now targeting with PARP inhibitors when we get into advanced disease screening and management. And as I said, we really sort of are just assessing the tip of the iceberg. These are the genes that, again, that we know about. This is the prevalence in patients with metastatic disease. So these numbers are a little bit, now the paper everyone always cites here is this Pritchard study, which is a bit old at this point, but the numbers are probably holding up pretty well, even as we're looking for more genes now. So about 12% of men with metastatic disease, 5% with overall localized prostate cancer, around 3% in the general population will have a detectable mutation in one of these genes. But these rare variants, these are all known as rare variants because none of these is all that penetrant. Even BRCA2, which is by far the most common, explains a very small proportion of diagnosed prostate cancers. The other way we look at germline risk is through these polygenic risk scores. And like I mentioned, there was an article just out in the New England Journal 2 weeks ago, which did not make it into the slide deck yet because it's a little bit too new, called Barcode, which is arguing to use a polygenic risk scores. This is looking at a couple hundred different SNPs, nucleotide variations in the germline DNA, to predict who should even have a PSA test. Now, I think that's a little bit crazy because, again, the PSA is $20. Just do the PSA first. But as far as thinking about how to interpret the PSA, this is going to have a bigger role going forward for sure. So this is just looking at deciles, or quantiles rather, of genetic risk, looking at the positive predictive value of a quote-unquote positive PSA test. This is a nicer study from Bartu Darsh, who's with Dan up in Seattle, which combined the polygenic risk scores with the driver mutations, the rare driver mutations. So the blue line here is patients who do not have a mutation in BRCA, CHEK2, ATM, or HOXB13. The lighter blue line, they do have one of those mutations, and then this is, again, increasing deciles according to the polygenic risk score. So you can see how important the driver mutations are. If you've got one of these mutations, it basically quadruples your risk relative to somebody that does not have a mutation. But the other way to think about it is if you are in the top decile of risk according to the polygenic risk score, it is as important as having a BRCA mutation in sort of the median PRS. Does that make sense? Everybody clear on what I'm talking about with these mutations versus the polygenic? Because the polygenic risk score is capturing much more of the iceberg below the surface of the water, right? The individual driver genes are the tip of the iceberg, and the ones that are easier to measure. But we are going to see more and more literature, I think, around the PRS. And remember, these polygenic risk scores are baked into that Stockholm 3 test that I mentioned earlier as well. So we're going to see this, I think, more and more frequently going forward. And this is not a particularly expensive test. It's about a couple $100 to do germline testing. Now, like I said, fine, we can find these. Do we know what to do with them? Should we be acting on them? So, okay, another show of hands. You have a patient with a grade group 1 and a BRCA2 mutation. Do you still offer active surveillance? Yes? No? No opinion? I'll show you the data in a second. BRCA 1 or 2? I think I said 2, but you would offer surveillance for BRCA 1, but not 2. Okay, fine. I'll show you the graph in 1 second. So we do know these patients do worse on average. Okay, this is patients with all comers, not necessarily low-risk disease, 3x increased odds of developing metastatic disease if you've got a mutation versus not. In terms of active surveillance, there's really only one paper so far, which is of decent quality. It's 2 centers, mostly out of Hopkins. It's not perfect. The numbers are pretty small here. The numbers in particular of patients with mutations is only a couple dozen. Okay, But still, it's the only one that has really reported outcomes for men with and without mutations. So the bottom here is BRCA2 alone. The top one is BRCA1 or 2 or ATM. And this is the likelihood of reclassification from grade group 1 to grade group 2 on the Hopkins intensive biopsy every year surveillance protocol. And without question, these curves are widely divergent. You are much more likely to reclassify to grade group 2 if you've got a biopsy, if you've got a mutation versus you don't have a mutation. To me, though, the question is, does that mean you can't do active surveillance? So if you look at these curves, you got a 50% chance at upgrading by 6 years. Okay, so we'll do surgery in 6 years, or we'll do radiation in 6 years. None of this is saying that that patient has missed the window and has metastatic disease. So, I'll tell you my own personal practice is I definitely offer surveillance to patients with any of these mutations, but it's real surveillance. They do not get to drift away to watchful waiting. They do not get to, extend their biopsy intervals to 7 years the way we're trying to do for lower risk patients. They need old school, every couple of year MR biopsy because eventually something is going to happen. But the window of opportunity to find that something is probably still measurable in many years. And it's important to point out these mutations are becoming increasingly actionable. If any of you are managing advanced disease, which is a bigger and bigger portion, I think, of urology practice, there's a growing number of categories of treatments which are explicitly approved or approvable based on identifying mutations in either the germline or in the tumor itself. So for PARP inhibitor, for example, if you have a BRCA mutation in either germline or tumor tissue, that qualifies you for PARP inhibition. There's lots of indications that being MSI high, this is more about the tumor than the germline, can get you into immunotherapy. And as we get more and more medications, you go to the advanced disease sessions here, we have more in the pipeline than we know what to do with. These all need to be targeted based on correlative markers to the patients most likely to benefit. And the reality is we're not testing often enough. So again, this patient qualifies, right, based on his family history. Not that many hands went up for should we test. So there are a couple. First of all, this was a study which actually looked at men eligible for testing for prostate among other for prostate cancer alone here, and of men eligible, relatively, so about 17% had a positive variance, and many of these would actually not have been eligible for testing based on the NCCN. So it's arguable that we should be testing even more, and it's a really important point to make that many men don't know their family history, okay, or there just aren't that many men in the family. And in either of those scenarios, having a negative family history doesn't tell you very much. So I have a pretty low threshold to order germline testing if we don't have a good sense of how the men in the family have done. And you need to know the details because even for cohorts who have a BRCA2 in the family, you will see some families where all the women have breast cancer, none of the men have prostate cancer. There's other families with a BRCA2 where all the men get prostate cancer. So some of these alleles are clearly more penetrant in the prostate than others, and you really need to know those details if the patients know, which they often don't. This is a really nice study Neil Shore ran, came out a year and a half ago now. They took 1,000 consecutive patients across a few large community centers in the US and just looked at whether they met criteria, according to the NCCN, yes or no. Did they find a mutation, yes or no? And basically they calculated the PPV and the MPV of the NCCN criteria, and they frankly weren't that great. So lots of men who met criteria didn't have a mutation. Lots of men who had advanced disease, who had markers, would not have met criteria. So there's a pretty strong argument to make that men who have bad prostate cancers should be offered germline testing, kind of regardless of these other parameters. And this is just a look at the specific mutations that they found. A lot of CHEK2 and MUIH, actually, even more so than BRCA. We've already kind of asked the question, who should do the testing? And this is very variable. It's all over the map. I don't think it matters that much. It depends on your local relationships with your genetic counselors and oncologists. UCSF, for example, actually switched a few years ago because we're doing so much more testing. So I used to send the patient to a genetic counselor to decide whether or not to get tested. Now I just order the test, and they see the genetic counselor if something pops up, just because of the volume and the workload. But it's there's lots of different arrangements, and I don't think anybody has any political feelings about this as long as the right thing is happening. And likewise, there are lots of different germline tests on the market. This is from that same Philadelphia consensus. I think the number of tests that are only looking at 5 mutations is actually falling by the wayside. The trend is that more and more of the major companies cover all the major genes and then some. Most of the ones that I'm sure you're familiar with will cover actually far more than just the prostate cancer genes. So that's about it. So take a good family history, but don't rely on the family history as a crutch. If there are no men in the family, patient was adopted, estranged from his father, whatever it is, have a low threshold to think about germline testing if you don't know the family history. We should think about testing more and more. It's cheap. It's got relatively few adverse consequences, and you can identify patients for specific targeted treatments as the subset of them that will go on to metastatic disease get to that point. So, is that it? Questions? Test more is the one take home here, and this is an easy one. None of us is up here as advocates for for biomarkers to make decisions about active surveillance, et cetera. But I think this is one area where, as a community, we really need to be doing more testing. No, I don't have again, no specific company, but get germline testing done more often.
That's exactly my question. So, 4K, ISO PSA, ExoDX, you name it. I know these people. I know their phone numbers. They know where I live, I think.
Yes.
But not germline testing.
Yep.
So tell those of us in independent practices where, how to get this done, or through what company.
Yeah. So, I mean, there are lots of different options. UCSF has switched. I can order one through our own EMR. So they were working with Invitae until Invitae sort of imploded. I think now it's Caris. There's Tempus has a combination germline plus somatic test. There's Color. What are you guys using? Ambry?
Now we use Ambry.
Ambry, yeah.
Myriad has their
That's right. That's right. That's right. Myriad is in the space.
Listen, if I was in private practice, don't forget the internal medicine doctor is also involved with this. Yeah. So I have a friend in practice near where I work, and he doesn't want to take that 87 gene Invitae panel and have to go through all the VUSs and then have to be on the hook and say, well, we don't know what this mutation means today, but then the next year we found out it's actually a problem. And then, who's going to make sure that person was contacted because we've changed all stuff? This is a lot to handle. So I think it's worth urologists to get involved and understand it and use it for your patients. But if you can't, at least you can call your referring attorney and say, listen, there are clear indications it's covered by insurance. There are other genes than prostate on this 87 gene panel. Maybe you'll find something else, like a pancreatic cancer gene, something like that, or breast, whatever it is, and then have that person. So my friend who's in private practice does that quite often. The point is, he gets the information. Doesn't have to bear the burden of it if you can't do it. Now, in the hospital setting, it's great. And our genetic counselors then will get involved quickly if there's a VUS, something like that. But keep that in mind, too. That's another way of doing this also.
Some of the companies will do this. So Tempus, which just bought Ambry, I think, they actually provide pre- and post-testing genetic counseling as part of the package. So it's part of the value for the test. I know they're not the only ones that do that. So that's another sort of selling point for some products. But, this is also not, I think the difference across these tests is pretty limited in terms of what we're looking for prostate cancer. So just find one where you have a good relationship with the local folks and stick with it.
You guys hit on a lot of stuff. Do you think you should do this testing if anybody is going to do active surveillance who has a high risk? And I preface it by saying I just did a gentleman who came for a second opinion. He had a 3-3 in one biopsy, 20%, PIRADS-3 on an MRI.
Yeah.
Strong family history. He had a BRCA2. I told him I didn't think he was a candidate. We went ahead and did a robotic prostatectomy. I haven't even seen him back yet, but I do have his pathology. He came back with T3B disease.
Yeah. So that's an image. So yeah, okay. So first of all, these definitely happen. Now we're going to talk a lot about active surveillance and markers in a minute. To be crystal clear, when I say, I would offer that guy active surveillance, the first step in active surveillance in our hands at UCSF is a confirmatory biopsy with an MRI ahead of time. And I would bet pretty strongly that we would have found that higher grade disease on the second biopsy with good imaging ahead of time.
And this is my PSA point.
Yeah.
I think you should go back to your radiologist who
Yeah.
did the MRI and say, listen, I got a great group 1 here, but he's got BRCA2 patients, he's very high risk. But if I have T3B on final path, educate the radiologist that either they misinterpreted the MRI
Big miss.
or I showed you that horrible MRI before. And maybe they told you it was fine, but that area was moved because he had gas in the rectum during this the DWI sequence. You know what I'm saying? But educate them.
Surveillance never means go home and forget about this. Okay. Even like that guy qualifies as like very low risk by the NCCN. He's the one who maybe doesn't even get a diagnosis in a future world, but still needs active surveillance. Absolutely needs surveillance. Needs the confirmatory biopsy for exactly that reason, okay, that you're describing. I think if you took, 100 guys to the OR from exactly that situation, the majority of them you're going to find were overtreated. There's obviously the exceptions that prove the rule, but that's why surveillance absolutely needs confirmatory testing, 100%. Yeah.
Back there.
Yeah, so my question is, we are moving to an era where, we are moving to a point where we are trying to do universal germline testing for a lot of patients for various indications, not necessarily urological oncology based indications. So my question is, given the fact that germline mutations are not going to usually change, right? You can do it one time in your life and it's going to be with you. Like for example, there are certain countries where, when they do the universal germline testing, they actually give the raw data to the patient and say, you keep it with you.
Yeah.
At some point in the future, when you have a disease, we can use that data to kind of risk stratify and things like that. So given that scenario, when you're doing the germline testing for a patient, would you rather advocate for a whole exome or a whole genome panel versus a targeted panel, given the fact that, risks and benefits and the data can be used later on for even other diseases?
Yeah, I mean, that's a great question. It's a big public health question. And no, I'm serious, and a big implementation question. We are seeing folks at UCSF who are like 37 years old, have their whole genome in a Pronuvo MRI that they got at the shopping mall. We're finding these little, they call it PIRADS 3 on a, biparametric non-contrast exam. And we're like, what are we supposed to do with this? So, the reality is, if we want to save lives in prostate cancer, the people that we need to be targeting for screening efforts are not the ones that can afford whole genome testing. And that's my problem with the barcode study, because that is the argument. The big advocates for PRS say you should get your whole genome read and read your prostate PRS at the same time as your cardiac risk and your Alzheimer's and everything else. Great. And the people that can afford to go to Mayo for the 50,000-mile checkup and oil change and all that are going to have all that information, and we're going to struggle to figure out what to do with it as a community. But for the majority of the population that don't have that, you got to start with PSA first, because it's cheap and it's accessible, and the primary care docs know what to do with it. Yes, if you've had a whole genome test, and you have your genome, you have your germline, you can read the PRS off that. You can look for these variants. But if we were talking about a prostate cancer practice, we're looking to help, make decisions for prostate cancer. I would say you start with the targeted panel. The polygenic risk score for overall risk, it's going to have its growing role. Okay, I mean, this is going nowhere. If any of you saw the movie Gattaca from the 90s, I mean, we're inching toward that state where, you stick your finger on the thing and it tells you, you're going to die of a heart attack in 30 years and your kid's not going to go to Harvard because, we're creeping toward that future, but we're not living in it yet.
One more question?
The genetic testing, it's going for, I believe its main goal is to tell us which treatment would be better for each cancer patient. Is that right?
Well, we're going to get into that a little bit. What I tell patients when they're in my office and this gentleman who would be a candidate for germline testing is I say, we can get this now, but it's really not going to help us that much probably with your decision. You could argue this gentleman it did because he had a BRCA2, so that might have, played into it. But for the most part, what I tell them is that it might help their family members, and they would have to talk about that. And I also warn them about the possible insurance implications, especially with life insurance. It doesn't affect health insurance, but life insurance. So they would need to meet with a genetic counselor. And then it might help us treat their cancer down the road because of these actionable drugs that we're talking about. But for most patients, it doesn't help them make their decision.
Okay, but one question. If we start doing this genetic testing in a patient, are we going to follow him with more testing in the future of treatments to see the change of the genes or?
Well, these are germline. So what these mean, they inherited them from their parents, and now it's in every cell in their body. We're going to talk more about genomic tests, I think, in a little bit. I think that's going more along the lines of what you're talking about, which are the mutations in deciding what to do with the individual patient.
Okay, because we're, right now, we got in our country, in Mexico, approved the lutetium since 2018, and we have been decreasing the radical prostatectomies. We're doing some more radio-guided endoscopic cleaning of the prostate cancers. And then we're giving them 177 lutetium and 3, 4, or 6, up to 6 rounds of the medication, and we're getting very good results.
Yeah, I've seen a few of those. You guys probably have too. A few of those studies are very interesting. Not really happening here in the States, but. All right, so for our index patient, show of hands, patients, everyone doing staging on this patient? Grade group 4, right? And are people doing CT scans, bone scans, or PSMA? So we'll go CT scan, bone scan. And how many are doing PSMAs? Great. All right, so we're going to have Peter talk to us a little bit more about staging.
Okay, we gotta move. All right, we gotta move. Which is easy because this stuff is pretty straightforward nowadays. By show of hands, PSMA scan seems to be the choice these days, and I think, for my practice, it is a PSMA scan. There were other types of agents I want to discuss, like sodium fluoride scans, other scans, but for the most part, this is an opportunity. I will give a caveat. So you'll get the PSMA scan for those that are unfavorable, intermediate, high grade. It's covered by insurance, at least for this country. But don't get overly alarmed by these soft, avid areas in the lymph nodes. But keep in mind that it will guide you in regards to that. Now, I also mentioned before, or was mentioned before by Matt, that we have ultrasound imaging tests that are different. And so if you want to stage your patient and also help with diagnosis, micro ultrasound, it's a more enhanced image analysis of the prostate. And then this just came out, actually, I think, a week ago, which was Laurie Koch's work, for which he actually presented this at the Engineering Society meeting this morning, where, in a nutshell, there is a non-inferior opportunity to say this office-based procedure with using a new ultrasound has a same type of MR characteristics in your hand. That's all. And then I'll before I go back to our last case, I'll add for one more thing on PSMA. When you stage the patient, consider the patient fit for surgery, active surveillance, or focal therapy. In this case, let's say the person wants surgery. But we have to decide whether, we're going to go ahead and take a lymph nodes are out. Now, it's controversial about lymphadenectomy based on the Gleason grade. I will say this. If you get a PSMA scan and there's some avidity of the lymph node tissue around the prostate and your radiologist says it's not very avid, but there's something there that's concerning, please don't just say, well, it's not clear, I'll leave the nodes behind. I think as part of what you heard from the index case, his brother had surgery for prostate cancer with a pelvic node dissection. And for those who are, looking to, take time off the case, it's easy to skip the lymph nodes. If you're at intermediate, unfavorable, or high risk, the PSMA scan has something there. I've seen people coming back with biochemical recurrence to my institution, and I look at the op report, and they didn't do the lymph nodes. I look at the PSMA scan, and there's a hint of something that is in the lymph node region, and now we're actually going back and doing pelvic node dissections on those patients because there's no distant disease. At the time of surgery, you're right there, take those nodes out. That's all. All right, thank you.
Thanks, Peter. So back to our index case. So our patient has a pathogenic BRCA2 mutation. How many are going to offer or at least discuss active surveillance with this patient? All right. And how many are going to do genomic testing? And how many would move forward with definitive treatment? He's young, he's in good shape, he's got a BRCA2, grade group 1. Trying to sway the crowd here. How did I do? Okay?
All the above.
All right, great. So we're going to talk a little bit about genomic testing. Thanks, Dan.
All right, thanks. We're gonna whip through some of the genomic tests that are out there available, and we're gonna kind of whip through a lot of them. Before we do that, just kind of some show of hands. Who uses Prolaris? Ever? Prolaris? Okay. GPS, the Oncotype GPS. Okay. Decipher. A lot of Decipher users. Artera AI. Nobody yet? Oh, one person. Okay, that's great. Okay, so we're going to run through all those. You'll have a lot of answers to your pre-test questions, I think, are in the next set of slides. So going to go through various aspects of genomic testing. So I tell a lot of my patients, particularly like this one that we just showed, I say, visualize yourself on a road. Your first fork in the road is surveillance versus treatment. And then the next fork, if you go treatment, the next fork, of course, is surgery, radiation type thing. And so we have this patient and we're at that fork in the road. Okay, so is there a way we can understand and how to, I mean, most of our decisions are based on that grade group 1, he's young, those types of things. But are there other aspects that we can use, other variables? And we're going to talk about the tests. But again, most of them are on that bottom point there, which is Gleason scores, PSA, its stage, and so forth, and age of the patient. So there are some various genomic tests that we're going to go through. The first one is Decipher. So Decipher was built on a cohort of patients. There are 600 of them. And if you look at those 600 patients, they were from the Mayo Clinic. They were kind of straddled the PSA era. Interestingly, a full third of them had metastatic disease. So this was not a low risk population. This was a rather high risk population that this was built on. I got to say that right up front. And then they used the tumor tissue. They found the DNA. They looked at all these genes, and they found out that we can actually stratify based on the genes alone, univariately alone. No clinical variables in this. Okay. When you look at the grade group 1, 2, 3, 4, 5, you can see that Decipher high. It just kind of makes sense. I mean, you can see it all like cognitively, visually makes sense. The higher the Decipher score, the higher the grade. Pretty well shown there. I will say that the grade group 1 disease, it looks like about a third of them were either intermediate or high. And probably the most relevant is 15% of the grade group 1s, like let's say our index patient, could have high Decipher grade. So that was how it was built. And this is a grid. This is a database that they use. This wasn't what they used to develop the test. One is also, there's also been many, and you can see here, there's 18 publications listed on here that are asking the question, we know a lot of things clinically about patients. You know, as I said, Gleason grade, stage, PSA, and so forth. We know now the Decipher. If we put them both together, are they better? And it is, in general, true. If you look at there, the AUC, 0.69 for clinical, 0.80 for Decipher, 0.81 for the both together. It is true. Decipher looks like, on average, works a little bit better. Although I'll point out there were a couple of studies like Study 15 and that actually looked like the clinical did better than Decipher. So it's not as if you can use it just by itself. At the same time, that's how it was developed, just by gene scores. I'm going to show all of their sample reports because I think it's important for you to see this, particularly if you haven't used it before. You get a score basically between 0 and 1. And there are the breakdowns right there. Like this patient is a high-risk patient, 0.80. That's pretty high. And again, determined by biology alone, you get a continuous risk score. And then over on the right side, if you're high, it gives you the chances of risk of metastasis, risk of death, risk of adverse pathology, and it just lists all the risk estimates. It's a pretty nice, pretty easy to read report. There's also a second page that goes through interpretation. I won't go through all this. It'll also show the risk stratification or a risk comparison by those here, by either low, intermediate, or high on this side over here. And then there's a QR code that patients can use sometimes. The Decipher is a single score, although within the Decipher, there's this so-called grid. In other words, thousands of genes. And Matt actually was an author on this very nice paper that took patients with grade group 1 and grade group 2 disease, 3+3 and 3+4 disease, and simply looked at how they were in aggressiveness over the whole scale of many different kind of signatures within the grid. And you can see there that the light blue is grade group 1. You can see there are some grade group 1s that are way up here in the pretty bad cancer. And likewise, there's some grade group 3+4 that are down on the lower end of the scale. This is basically showing the spectrum of disease that Decipher is or the grid here in this case is trying to show that not all grade group 1 disease are the same. What about those active surveillance patients? Now, I'll point out on this slide, this is actually a subset of favorable intermediate risk. So this wasn't necessarily the low risk. This is favorable intermediate risk men, and it showed Decipher low had a chance of adverse pathology being only 13% and Decipher high being 41%. So clearly, maybe if you're thinking about doing active surveillance in a favorable intermediate risk, Decipher might help you on this, and I'll come back to this on a future slide. They've also done multiple studies within the NRG or RTOG, the radiation literature, and this is one of them that was showing if you do a Decipher high versus low, you can actually predict 10-year metastatic disease rate. And the interesting thing about this, and I'll say this a few more times, is they did this on a group of men that were actually in a clinical trial. So they were already enrolled in a clinical trial, they already had outcomes, they took all their tissue, or at least what they could find, and they did a study and they looked at those men with Decipher high versus low, showing that it can predict metastatic disease. So it's very prognostic in this way. How is that being used now prospectively? Well, prospectively now, there's a really interesting trial called Guidance, which you might have running on your site, where they're taking patients, again, with unfavorable intermediate risk disease, and they're doing a decipher right at the front end. If they have a decipher low, they get randomized to radiation therapy alone versus the standard of care, which is radiation plus hormonal therapy for 6 months. If they have a decipher high, they get randomized to radiation therapy plus hormonal therapy for 6 months, which is standard, or augmented hormonal therapy with darolutamide. So both arms in the middle there have the standard of care. I think it's a great design. That way we're going to get some answers from this, okay? Unfavorable intermediate risk disease. They've been doing some very similar work in high-risk disease. And again, looking at all these RTOG trials, all these phase 3 clinical trials, level 1 clinical trials that looked at radiation therapy algorithms or different treatment paradigms. And they looked at how does Decipher in those patients predict metastatic disease. You can clearly see that high Decipher had much higher rates of metastasis at 10 years versus lower Decipher. You can see there, again, cumulative incidence of metastasis. So Decipher might predict in many ways who's going to have metastatic disease. So why don't we use it in a clinical trial? So now here's PredictRT. PredictRT is an NRG trial, GU009. Again, what is the standard of care for high-risk prostate cancer for radiation? Well, it's radiation plus 2 years of hormonal therapy, right? So in both of these, you have that in the middle there. If they have a low Decipher, they get de-intensification, so only a year of hormonal therapy. If they have a high Decipher, they can get augmented hormonal therapy. And again, the common arm is in the middle there, which is what the standard of care is. So that's called PredictRT. It's a really interesting trial that's going forward. There's been validation of this. I won't go through all this, but this was in the so-called Stampede trial, where there was actually the addition of abiraterone. And again, Decipher can predict those that would benefit from the addition of abiraterone. All right. For sake of time, I'll move on to Prolaris. So Prolaris is another gene signature test. Some of you raise your hand. You're using this. I use this actually quite a bit for the newly diagnosed prostate cancer patient. I'll tell you in what arena. This is biopsy tissue again. It's really been built on mortality, biochemical recurrence, and there's some decision-making trials out there. Now, how has this been formed? How is this designed? Well, it used clinical variables, PSA, Gleason grade, of course, and then it has this cell cycle proliferation score. This goes all the way back to all our medical school. You learned about Ki-67, right? Cell cycle progression, how fast a cell's dividing. It uses it in there in an algorithm, and it spits out the chance of either disease-specific mortality or metastatic disease. Again, I'm going to show you some sample reports. So this is a patient with unfavorable intermediate risk disease. You get a sample report. It shows you where along the spectrum, maybe active surveillance or single modality therapy or multimodality therapy that this patient might fall. It also gives a chance, of course, just like the other reports, disease-specific mortality, perhaps metastatic disease, and then it shows where they are along the spectrum. So you can see down here, this unfavorable intermediate risk patient, the triangle is the median, so slightly less aggressive than the typical unfavorable intermediate risk patient. It's a good output. It shows you some aspects about where the patient falls. There is this so-called active surveillance threshold. I was involved in this study where we had a pretty big training cohort, over 1,700 patients, and we validated it. And basically, we were asked the question, is there a Prolaris score upon which we can say below it, there's very little chance of having something happen over time, like metastatic disease? Maybe that's the active surveillance threshold. Again, we trained it, we then validated it, and here's the bottom line. When you see here, if they're above this threshold, if they're below this threshold, the dotted lines there, they're very, very low possibility of having any mortality. In fact, there were no prostate cancer deaths below the threshold, whereas above, you could see that they had a high risk of having metastatic disease. So we call that now the active surveillance threshold. I don't think that's in other tests. They also looked at those in radiation therapy and looked at the risk of metastasis and who might forego multimodality therapy. In other words, again, the standard of care for radiation would be radiation therapy plus hormonal therapy. Well, can we avoid that? Just like what Decipher was trying to do. So when look, see here, this is a large training cohort, and another one. This is just reported by Jonathan Tward. And when you look at this, the dotted lines there, again, were below that threshold. there were really no metastatic disease or very few. If they're above the threshold, then whether they got both ADT plus radiation in the orange or whether they got just single modality was quite a bit difference. Okay, so again, this may predict who should undergo multimodality therapy. I'm going to move on to the second to the last one. I'm going to have Artera AI and then this GPS Oncotype. Several of you say that you're using the GPS test. And again, this is a tissue-based test to understand the degree, the disease aggressiveness within the tissue. It's looking at 12 prostate cancer-specific genes across 4 pathways, plus the blue box there, which is clinical factors, and it spits out this genomic prostate score. And again, the way that this works is clearly when we look at the risk of adverse pathology, and that's what it's testing, is actually the target is adverse pathology. If one were to take out the prostate, what's the chance you'd find adverse pathology in that prostate? And typically we would say to ourselves, well, if it's low or very low or intermediate risk disease, let's take low risk disease, the middle dot there. If we took men with low risk prostate cancer, we took their prostates out, there'd be about a 20 to 30% chance we would actually find, well, in that case that you mentioned, T3B disease or something worse in the prostate. But if we did the GPS score, it tells us where along the spectrum, like all those little dots, are patients. All right. And there's this big spectrum that one can have, even in low risk disease, such that if you take this patient right here, that patient has low risk disease, his GPS score is 60. His chance of having adverse pathology is at the very top of that curve. It's over 60%. All right. So again, would you want him to go on active surveillance? Probably not. Likewise, if there's a patient down here, his low risk disease, his chance of adverse pathology is less than 10%, probably a very reasonable patient to go on active surveillance. So this has been validated in a number of studies. I won't run through all of it, but it clearly looks like it predicts metastasis and death within about 10 years of prostatectomy. This is one of the major studies that were put out there, that every 20 unit increase in GPS has a 2-fold increase in metastatic disease, as well as a 2.6-fold of prostate cancer death on that curve there. So clearly it's been validated for all the key endpoints for prostate cancer. With regards to external beam radiation therapy, it's always the same. It's exactly the same results. This is a study that was released just a couple of years ago. Same thing with every 20 unit increase in GPS, and after radiation therapy, it does appear to have predict death from prostate cancer and metastatic disease. I told you I'd show all the reports. This is the report from GPS. You can see there are 2 side by side: low risk report, a high risk report, where they are amongst the spectrum. You know, I tell all my residents, life is a bell-shaped curve. It is. Most people fall on the bell. All right. The people that you benefit are on the either end. Now, again, I'm showing you on either end. Most people that you're going to order these tests on are going to probably fall on the bell. But again, it can help. We can do the numbers of how many it actually helps. But it is interesting to maybe guide decisions on what therapies to do. Again, low risk report. I will say on this low risk report here, I mean, first of all, it tells you where they are on the low risk report, likelihood of adverse pathology. The thing that I don't really love about a low risk report, I mean, in some ways it's okay, but it talks about metastatic disease after radical prostatectomy or prostate cancer death. I think we would know that even just by not even doing this report. The chance of metastatic disease at 10 years is incredibly low, almost regardless, particularly if we do good active surveillance. I think for 6 time, I'll just go through the comparison of the 3. Here are these 3 Pearl areas, GPS and Decipher. Again, you can see what their endpoints are. The reports are showing very similar aspects. One's more like conservative treatment with death. The middle one is adverse pathology. And the last one is mets and death and so forth. They're all prognostic. They're not all predictive. I think for Decipher, it does appear to be predictive for RT plus ADT, which we'll go into a little bit more. And at the end of the day, I think who should we do these on? Who do we think we should do these on? This is a very nice ASCO guidelines put out many years ago, but I think it's still relevant. I mean, do it only for those you're going to change what you're going to do. And the example scenarios are high volume grade group 1, high PSA density, low volume grade group 2. Those seem to me the sweet spot. All right. They're not recommended for routine use as they've not really been prospectively tested, particularly for determining active surveillance use. The last one is Artera. This is a new one, as you know, looking at histopathology. I mean, here's looking at the picture. It can give you prognosis, outcomes, prediction. It's very clear we can learn a lot from this. It can be a very robust model. It can learn on its own over time. It's looking below the surface. I still think the last 3 points there are the really key ones, which it can be quick. You have the tissue already. It can flatten the world a little bit. You can have somebody in the sub-Saharan Africa send their slide, and you kind of know it. It's actually pretty nice. It can, and I think that's really going to be. It could be a game changer. I won't run through the development of it because I don't understand it. It's mostly taking images, doing a layering, and eventually coming out with clinical variables. There is a black box, so they do use clinical variables. Okay. And how does it perform? Well, it's been looked at largely in the radiation therapy trials. All right, looking at how does it predict distant metastasis? How does it predict biochemical failure and so forth? Again, using clinical variables. In this publication, it was testing it against NCCN, which is a really low bar in my opinion, but it clearly beats NCCN. I think a lot of things beat NCCN, but it clearly beats NCCN. How about its predictive abilities? And this is the sweet spot. So if there's anything you can take home from this, and as a urologist, we might not use it as much for this reason, but how does it perform to predict who needs hormonal therapy? There have been some great studies, okay? And so again, they used randomized phase 3 clinical trials, and they did the Artera test on it. And when they looked at those patients who either had radiation alone or radiation with hormonal therapy, if they had a low Artera over here, it didn't matter whether they got hormonal therapy or not. They all did the same. If they had a high Artera, they clearly benefit from hormonal therapy, all right? 2/3 of the patients had a low Artera score, so they could have been spared hormonal therapy. So I think to me, this is the best take home. This is really nice data to show perhaps who might benefit from hormonal therapy and who can avoid it, okay? I think that might be it. Oh, just the test report. It kind of looks deciphery. You get a score basically from over there showing low, intermediate, and high. It shows you your percent risk. It shows you if you're positive up there for that standard ADT with radiation therapy. And then this just recapitulates exactly what I just showed on the previous slide. It's a really nice report. I think we can skip those, yeah. Great. Peter.
Yeah, well, that was very good. That was a comprehensive. Listen, I'll admit I struggled with this part in my paradigm for my patient care. I struggled with this tremendously. Any questions or anything? This is a lot to digest, a lot of information, quickly. Yeah.
It's a good question. I mean, the Artera test, if you look at the NCCN guidelines, it says low risk, but it says low risk to determine ADT as well as distant metastasis and death from prostate cancer, which is, as I said, exceedingly rare in well-done active surveillance. There have not been great active surveillance data with Artera. There just hasn't, or we would have put it up there.
There are actually no published active surveillance data for Artera so far. So, and it's Dan made the comment about the reports. None of the reports is very good for these companies. The science gets done in collaboration with people like us, with academics, and it tends to be very good statistically. The reports tend to be drawn up by marketing departments, right. And there's a lot of misleading presentation of some of this information, and all the companies are guilty of this, without exception. There have been phases over the years where some of them are more egregious than others. Currently my two, the one on my hit list is, Polaris has this box saying, you should do surveillance, you should do single modal, multimodal treatment. That is ridiculous. No matter how good these tests are, none of them should ever be construed as telling you what to do. This is information that you as the clinician need to incorporate with everything else you know about the tumor, imaging, clinical information to help that patient make the right decision for him. Okay?
Every patient's different.
Yeah.
Right. So my problem with these tests, honestly, is the spectrum. Right. So I had a GPS score, and I gave it to the patient. I said, well, great news. There was a 40% chance you have a more aggressive cancer than we think. No surveillance for you. We're going to go to surgery. I'm going to cure you with surgery. He's like, 40%. I have a 60% chance that I don't have that problem. I'm like, and then I could have said the same thing to the next patient. They'd be like, oh, 40% is way too high. Yep. And so a company shouldn't be telling me what to do.
Yep.
Right? It's a patient's decision.
It's patient decision. And the Artera one in particular, to be very clear, they have some fantastic papers. They're moving very quickly. They had New England Journal evidence last year, a couple of the great papers specifically for the question of if you are doing radiation, should you intensify that with hormonal therapy, yes or no? For that question is level 1 predictive. For everything else, I have a poster downstairs on this. Kevin Hughes, our resident who just walked out, has another poster at ASCO on this. The data are coming, but they are not there yet. So, they're moving very, very fast. And it's good for them they're moving fast, but, let me take a breath. Thanks for coming. Awesome.
Thank you.
AUA.
Thank you.
Please fill out your evaluation.
Do fill out the evaluation.
All right, two quick things, just because we are falling a little behind in time, and we want to try to get everything in. I promised I would answer questions from the audience, so I am. It is, once we identify a germline mutation, is the data discoverable by life insurance companies? Should they be genetically counseled before we get a Tempus? Great talk as always. I believe it's protected from life insurance companies, right?
There's a law called GINA which explicitly disallows carriers from dropping patients when they are found to have genetic anomalies. Now,
But life insurance,
yeah, I think it's different by state, and this is why the genetic counselors get involved with this. I think if you have a policy, they can't drop you, but if you don't have a policy and you have this on your medical record, it can be a little bit more difficult to get policy, and it does depend on the state a little bit. And this is where the counselors know more about this than.
yeah, I kind of make it personal. So my daughter's mom died of breast cancer. My daughter has to make a decision of when to be germline tested. She's 24. She's not doing it now because she gets tested now. Her life insurance is going to cost her. She doesn't need life insurance now. No one's depending on her income. So she'll get tested at the right point in life to just sort of decide that. But for my patient in front of me, I say, look, you've already got cancer. If you go to get life insurance right now, even with prostate, we've all probably been down that road writing letters. You're probably not going to get your insurance. And just because I want everyone to do well on the test, as Dan showed, the Decipher test is a little bit more univariate. So if anybody has problems with their pathologists, I can name a few distinct pathology groups in New England where I'll get people in, and they have a Decipher score of 0.83. Pathology, not bad. Our pathologists review it, and they're grade group 4 disease. So it's just one other thing to sort of bear in mind.
One other comment about the 0.83, by the way. One other issue with these reports is that they all have a threshold because you kind of have to put a threshold on there. But these are continuous variables. And when you look at Decipher, it's kind of a perfect example. It's a 0 to 1. Anything over 0.6 gets called high risk, and you're in the red box on the report. There's a big difference between being 0.62 and being 0.93. Okay, and the guys that are in that really high, like 80s, 90s range, that's the bad biology. And those, I personally think about quite differently from the ones who are in the 60s.
All right. So we'll move quickly through this. First of all, active surveillance is different than watchful waiting. So watchful waiting is you're expecting a person to go home. Life expectancy is going to be short. And as a result, if they have a recurrence of if they have a progression of cancer, that's okay with symptoms. Active surveillance means you're actively involved with the patient's care and looking for a change in the biological aggressiveness for which you can intervene and at that time still provide cure. And so that's important to keep in mind. Very briefly, I think MRI here, it's a challenge to think it could do much better than what we have from large series from Toronto and Baltimore, other places, for what we call very low-risk cancer. And so really, I think the opportunity is here is to comfort the patient I mentioned before and the physician to engage in surveillance. Also, it's not a failure of surveillance if you expect to treat this person in the future. 4 or 5 years of quality of life is important as long as the window to cure doesn't close. And that's important for the patient to understand. You're going to treat them so before that window to cure closes by intervening. Now, the last thing I'll say is this, is possibly, biomarker tests and imaging can de-intensify the morbidity of surveillance. How we do that is unclear, but there's opportunities for that. We don't have time to go through it right now, but keep that in mind. These type of tests and imaging can space things out a little bit more often and then allow the morbidity to decrease. And I'll skip through this. Additional imaging tests are coming down the line. PSMA tests, there's a lot of information right now about opportunities to look at other modalities besides MRI to select and make sure that you're putting a person on surveillance who would not be disadvantaged by going on surveillance because they're a much higher grade. Now, MRI, as I showed before, does a great job. PSMA, something else. Other ultrasound imaging modalities like microultrasound or maybe multiparametric ultrasound in the future. And then for treatment planning, the other thing too is this. We want to offer surveillance for quality of life. If I could tell a patient, after my procedure with you, you would have the same exact quality of life, 100% guaranteed, no doubt, they would skip surveillance with a heartbeat and go for that. That guarantee does not exist. But there are modalities now to decrease the morbidity. And there was a big discussion at this meeting about focal therapy. And so, for example, as you incorporate that in your practice, or if you want to have somebody in your practice who does it and you can refer that to them, keep in mind this is the difference between surveillance and radical whole gland therapy. We happen to do laser, we do ultrasound, we do other modalities. Imaging is important. You can have follow-up imaging afterwards. And lastly, if you're going to go to surgery for this patient, do not ignore the MRI. Get the MRI in your practice. Go through at least the T2 images in 2 planes, axial and sagittal, because cases like this do exist. You know, person went for PSA, right to 12-core biopsy, got this information, no MR information, right? Sent over to me for an MRI of the prostate. Keep a long story short, he was not grade group 1, and this anecdotal case will be in your practice for sure. And so therefore, have the MR done, look it over, because what you would have seen on the MRI is that there was an extension through into the neurovascular bundle, which the radiologist did not mention. So for the person who left with the T3B disease after grade group 1, you know, this image quality, even a first-year high school student can see that there is a line for the capsule and something that's going through it. Who knows what it is? We changed the surgery based on that imaging. I did nerve sparing on one side. You can see on the other side, which is to the right of the screen, we went wide, and the tumor was through the capsule, but the margins were clean. This young man had a 10-year-old boy when we did the operation. He's now graduated from medical school, so that's at least 8-10 years since I did this case. With no adjuvant therapy, his BCR has not occurred yet, and therefore, the only thing I want to say is, if you have the MRI, look at it as you go into the OR, that's all.
Thanks, Peter. Another question from our virtual audience who has 2 concerns about germline testing. Has anyone looked at what happens to families that the prostate cancer patient had the test and found a germline test? I imagine some family members would be happy to know and others not. That's clearly the case, but I have had people come into my room and thank me because their sister got tested, had breast cancer, had a mastectomy, and did great. He's also concerned about privacy and the way things go in the country. Look, I get it. You know, tell Alex Rodriguez that his urine test was confidential. Doesn't seem so confidential years later. And then what can the government do with the information? So, valid concerns. So back to our index case, we finally got our wish. This gentleman, though, did get genomic testing, had a GPS of 42 that further confirmed the need for definitive therapy. He had a radical extraprostatic disease, a focal positive margin. So how many patients, or how many people rather, would offer adjuvant radiation at this point due to his adverse features? Few randomized protocols out or trials out there that supported doing this? No, nobody does anymore. I don't think anybody really was, but with raves and radicals, we're certainly not. So most people are observing. And how many would do molecular testing on this patient, genomic testing, with either Decipher, Prolaris, anything else? Show of hands. All right, great. So Dan's going to show us a few slides on that, and then we'll discuss the case.
Okay, so there are a couple options for patients who are wanting to know about the risk of having something happen in this case. So somebody has a positive margin or a pretty aggressive disease. Should we do earlier radiation therapy, or should we add hormonal therapy at time of their recurrence and so forth? And I think the data are pretty good. We'll kind of whip through most of it. So again, here's the situation after surgery. Do we do early-ish radiation therapy or observation? If we do radiation, do we need to give hormonal therapy? Those are the key aspects that are happening here. I'll just cut right to so there are 2 tests that really look at this question. One in particular that does it more, which is Decipher. Okay, the Decipher test does look at, this is a typical post-op report, a post-radical prostatectomy report, looks very similar to the one prior. Again, gives a risk score, gives a risk of METs, risk of death. This is for high-risk prostate cancer. But really, what's the data that support this? It's really pretty interesting. This is one of the first ones by Bobby Den, now 10 years ago, but it's held up over time. Whereas if a patient has a prostatectomy and their Decipher's low, whether they get radiation therapy early-ish, like less than 0.2 on the PSA, or where they wait until their PSA's over 0.2, then they're no difference really in their instance of metastasis. But if they have Decipher high and they get an earlier radiation therapy versus later after 0.2, you see quite a bit difference. So maybe in a patient that is you're thinking about giving radiation to, and you want to know whether they're at a higher risk, this has been evidence to get a Decipher score. This is held up over time again. This was another paper that showed, again, at PSA levels that are low, less than 0.2 or 0.2 to 0.5 or even greater than 0.5. If the Decipher was low, their chance of metastatic disease still was pretty low, regardless of when they got the radiation. But if they got radiation earlier with a Decipher high, it was much better that you see there. Okay, and again, it's been borne out over time. I won't go through all the series. There have been other really what I call practice-changing reports that have come out on the addition maybe of hormonal therapy to radiation therapy at the time of BCR. So you have your patient, got radical prostatectomy, doing okay, the PSA starts to rise, going to give salvage radiation therapy. Should you give hormonal therapy with that? There have been a couple studies that looked at that. It was pretty interesting. This is one of them. There's issues with this one, which you can get into if you want to, but the bottom line was this. If a patient had a Decipher low, and this is the chance of distant metastasis, prostate cancer mortality, or overall survival, Decipher low had minimal benefit for the addition of hormonal therapy. If anything, overall survival was actually lower in men with Decipher low that had hormonal therapy, of all things. But if the Decipher was high, then the addition of hormonal therapy clearly benefited from them, okay? So again, that's been borne out over time. I think that that's really a predictive model. Prolaris also has a very similar report. If you do a radical prostatectomy and you send the tissue to Myriad for a Prolaris score, there is a post-prostatectomy result, again, showing where along the spectrum that patient is. And again, I'll just show one study. This is actually Matt's study, looking at a high versus a medium or intermediate versus a low CCP or Prolaris score, showing a variable progression-free survival in from the radical prostatectomy specimen, all right? The one that also has it stratified by different subgroups of Prolaris score, again, shows the higher the score, the higher the chance of metastatic disease or mortality. So again, you can send both the Decipher or the Prolaris after prostatectomy for these predictive scores. I think that's it. Oh, just a summary. Yeah, it stratifies patients within each risk category. I think it does show, without any other additional high-risk features, an independent score.
All right, so back to our index case. So this patient was sent for Decipher testing. His score was 0.76 on a scale of 0 to 1.0, so that's high. He had an undetectable PSA until 18 months post-op, and then his PSA went to 0.03, 0.04, and 0.07. And then he received salvage radiation therapy with ADT based on the studies that Dan discussed, as well as RTOG 9601. So my first question, and I think I'll ask the panel, is if you're doing these genomic testings post-prostatectomy, when do you get them? Let me start with Matt.
Yeah, I mean, I think for patients who are facing a decision about whether and when to do treatment, it makes a lot of sense. And it is a little difficult to apply one of the retrospective trial analyses directly to say if X, then Y. But the Decipher to me helps me kind of set the thermostat of how high we're going to let the PSA drift. So the higher the PSA, the earlier we want to come in with radiation therapy. Now, say in 19, I would have sent this guy for radiation with a PSA of 0.7 with a Decipher of 0.76. In 2025, we wait till 0.2 because we want to get the PSMA PET scan. And the yield on the PET is very low until you get to 0.2. And the data to suggest that you are losing ground in terms of curing the cancer at 0.07 versus 0.2 are pretty limited, honestly. So I tend to wait till 0.2. Now, if the Decipher is low, I will let it drift a lot higher, especially if it's going up slowly.
Interesting. So I'll say what I'm going to ask. So what I do is I get the Decipher on all the bad pathology reports. And the reason I do it is I tell them, you've met your deductible. You had a PSMA and an MRI and a surgery. If ever you met your deductible, you met your deductible. We're going to get your Decipher test. I'm going to put it in my back pocket. And if your PSA is 0 forever, we're great. If you have a good Decipher and your PSA goes up, we're going to pump the brakes and watch. And if you have a high Decipher, I'm going to treat you a little bit more quickly and more aggressively. So this is a guy that I probably would treat. To be honest, right now I'm radiating about my salvages, 85% of them have a PSA under 0.2 because the writing is just, I just think it's on the wall with this guy. Dan?
The PSMA PET thing is interesting. It's tough because you're kind of caught in a little conundrum. Do you want to do it early, like really early, and maybe decipher might help that, or do you want to wait till 0.2-ish so you can get a PSMA PET? And it's a constant battle.
You don't lose, like you said, for every 0.1 of PSA up, how much do you lose, right? 3%?
Yeah.
Maybe?
In terms of PSMA PET?
No, I mean, if you're doing your salvage radiation therapy, with each increase of 0.1 of your PSA, you lose a few percentage points, right, of PSA biochemical recurrence.
The trade-off is knowing where it is, right? So because the PSMA PETs not uncommonly show us lymph nodes that are not in the typical pelvic landing zone. So
Perirectal.
perirectal,
Yeah, classic.
in the chest, we've seen this, right? It skips the pelvis and goes somewhere else. So, and you're not going to find, because we are now adding on, let's say, at least 6 months, if not 2 years of hormonal therapy, given the high decipher here, the out of field node, which has not been radiated, you're not going to find for a while. So I agree, it's tough. We don't have an answer on this. Our current practice is we want to get the PET result.
And would you guys give, like, I would only give this guy 6 months.
It's not
Would you give him longer?
It's up to you. It's not up to you. It's not. It's up
Yeah.
to the radiation oncologist. And I've told patients to go in and say, listen, ask for 6 months. But they say, well, they counseled me on this information. They said, well, we're giving you the radiation. Your surgeon did his job. Now you listen to us. I mean, that's flat out what happens. And by the way, I would say this. Your patient needs to have a hard conversation with radiation oncology. If you're in the room, cover your ears, your right onc, because they downplay the harms of salvage radiation. Are they in one pad? Are they at a pad? Are they in 2 pads? And I've had into, respectful arguments with my radiation oncology team by saying, listen, it's important to remember that these are harms that are lifelong. So, don't just say, I want to radiate you early. And if the patient buys into the harms, then that's a different story. But they control that, at least in my practice.
I'll take it a little bit of a different direction. She was showing that, the harm of ADT if a patient has a low decipher score and he doesn't need it. So we're all trying to avoid it. Are you guys still using Lupron, using more Relugolix? What are people doing?
We're a mix. Yeah.
Yeah,
Relugolix is
same.
very expensive.
Yeah, same.
It's a high out of pocket. I think for patients with a lot of cardiac disease, we might lean that way. 6 months, probably not a huge difference. It's
Right.
Long-term, 2 to 3 years of treatment. I think the one shot is easy. The question is, again, if we got a positive PET scan, do we intensify that early with other treatments, other ARPs or chemo even early? And we are doing that in some cases when there is nodal disease in the PSMA.
And I think the trend is for longer hormonal use. I just do. I think it says 6 months, but I think if one thinks about our experience with higher risk prostate cancer or high risk prostate cancer, and those men getting radiation therapy instead of surgery, it's 2 years, and it might be 12 months after this. So I think that the trend, I've heard a lot of medical oncologists and radiation oncologists say, hey, let's aim for 2 years. If we get 1, we're fine. That's like the trend. Although I think that everyone would rather do 6 months.
But listen, there are people out there who they get permanently castrated.
Oh yeah.
They don't remind them that, right? And now it is age specific, right? So you're 60, you bounce back. I've had guys in the high 70s and they just never came back.
Yeah, that's true.
And this is another really good use for these markers. So remember, there was a poster downstairs earlier that quoted Eric Klein that no man that's ever had a biopsy wants a second one, right? The equivalent is men will go to the mattresses to minimize their ADT exposure, right? And both Decipher and Artera pretty explicitly, if those tests are low, you can with some good confidence turn down the ADT exposure. Whether you go to 0 or a shorter course, I think is debatable. Of course, sometimes the tests are discordant and we don't really know what to do, and we're still learning that, and time will tell. But we often talk about these markers both before and after diagnosis for finding the bad thing, right? Find the cancer, predict the recurrence, predict the metastasis. There's a unmet need here to really figure out how to use these tests to de-escalate, to figure out who doesn't need a biopsy next year, who can go on less active surveillance, who can skip adjuvant radiation therapy even if the pathology looks bad. And that's a big, there are a lot of patients who will benefit from using the tests in that way, and it's important from a public health standpoint. So bear that in mind.
So we have 2 more minutes. Any other questions? I encourage everyone to try to win $250. Sounds like a good deal for a few questions to answer. Yes.
So hopefully this is a situation that doesn't come into real life practice, but if it comes to it, and after radical prostatectomy, assuming that the margin comes positive, and we know that the patient is a high risk Decipher or Polaris or whatever. So how do we incorporate that into deciding whether the patient needs salvage versus adjuvant radiation? Because it is, I think the onus is on the urology team to send them to radiation at the right time. So how do you factor it in? I know that it is not a white-black answer. It's a gray area. So what in your experience, what other factors will you consider to decide between salvage and adjuvant, given the fact that in a disease like prostate cancer, it's more of minimizing the harms of treatment rather than other things?
So your Decipher score or Polaris score is concerning for high risk.
High risk.
And you have pathologists. So what I would do in that case is I would want the patient to understand the harms and benefits of additional therapy after surgery, right? And that includes radiation and the ADT duration, whatever it is. And, at this point in time, I would put that in the hands of the radiation oncologist to discuss the harms and benefits, as I don't want them discussing the harms and benefits of surgery, right? And then at the end of that conversation, they often call me back and say, listen, I had the counsel. Hey, I have a 2% risk of having worse incontinence. I'm at a pad a day. I'm 9 months out. I still can improve my continence. I'm going to wait 3 months. I'm fine with that. Or you know what? I don't want to die of cancer. I'll take an AUS. I'll take a sling in the future. I want radiation yesterday. And so I hate to put this on the patient, but that's why they were involved. It's their body, their lives.
All right. Well, if anybody else has any questions, feel free to come up. We'll be here for a few minutes. And again, thank you for participating. We really appreciate it.